FOV only for that segment which is required. So again, be specific when you use a CBCT. So finally, coming to the therapeutics. How do you decide what drug and how much of drug has to be given to a pediatric population? You have Clark's rule, but it's difficult in the OP to sit, calculate the weight, height, and then do a mathematical formula and then formulate. Very, very simple. A child of 1 year, you give 25% of the adult dose. A kid of 6 years, you give 50% of the adult dose. A child of 12 years, you give 75% of the adult dose. From 16 years, you give a full adult dose. A very, very easy clinical formulation. Again, you will have to give the instructions to the caregivers when to give the drug and when not to give the drug. Sometimes parents will have to go to work, they combine the afternoon drug with the morning dose and give it and go. Never do it. As far as possible, a practical tip, when you're prescribing for kids, see that your drugs are given with the food. Try to cut a midday or a mid-afternoon dose. Whenever the child takes meals, try to cover your drug coverage during that period. Form of the drug. It's always a suspension or a tablet. Parenteral routes are usually not given for children. Again, topicals, especially antibacterials. Never give for a child a topical antibacterial because it can cause a sensitization or a hypersensitivity reaction. So try to have it with suspensions. And if you're going to give any gel to be applied, make sure or train the child to expectorate it and not to swallow it when asked to do it. I'm not going into the pharmacology of each drug. As per evidence-based practice, these are the drugs which are safe in children. Mild to moderate pain, acetaminophen or paracetamol. A maximum dosage of 325 milligrams has to be reformulated. Moderate to severe pain. You can give ibuprofen or naproxen 220 mg. In severe pain, the best drug for a kid is naproxen 220 mg tablet, depending on the weight. The maximum dosage is available because it has got a very, very fast dissolving power. The peak concentration and the blood levels are reached very fast. It has got the least toxicity out of all the analgesics. Codeine, morphine, tramadol, absolute contraindication for pediatric population. You will have to manage only with these 3 groups of drugs. Yes, in case of antibiotics, again, it's a mispractice amongst especially the younger generation to couple an antibiotic with any dental procedure. If you look at the hot topic for research or for grant in the current day is antibiotic resistance. And worldwide, it's the dentist who is contributing maximum to this development of antibiotic resistance. Why do you want an antibiotic if there is no infection? You do a root canal, why do you want an antibiotic? Just an anti-inflammatory is good. Unless clinically you have an evidence of an abscess or a cellulitis, or you find some infection, you are justified in using an antibiotic. Otherwise, just an anti-inflammatory is going to do. Amoxicillin is the safest. It's available as a suspension, a tablet, a capsule, whichever form you want, you can use it. For mixed infection, if you want to go for an augmentin, you are allowed to have a potassium clavulonate, but reduce the dosage of potassium clavulonate to prevent gastrointestinal tract upset. Azithromycin is the first alternative if the kid is allergic to or a type 1 allergy to penicillin and cephalosporin as cephalaxin. Azithromycin is good, but if you have a child with a cardiac disorder, a congenital disorder, or a conduction disorder, azithromycin and clarithromycin are contraindicated. Because for a patient, even for adults, for a patient with a cardiac disorder, if you're going to give azithromycin and clarithromycin, it's going to induce cardiac arrhythmias. So be careful. That's why history is very, very important. Cephalaxin, yes, as an alternative you can use as a suspension or as a 125 milligram tablet. best antibiotic as of now for a very, very deep-seated infection is clindamycin for both pediatric as well as adults. Adults, especially if it's an osteomyelitis or a deep-seated infection, no other antibiotic has got a better bone penetration than compared to clindamycin. But the red line, you can never use clindamycin for more than 15 days. Because if you start using it more than 15 days, you're going to induce a gastrointestinal tract complication called as pseudomembranous colitis, which causes abdominal discomfort, watery stools. So 15 days you can use it. Tetracycline and doxycycline. Literature says it's contraindicated below children 8 years because it can cause a permanent discoloration of the tooth and a hyperpigmentation of the soft tissue. But we have a provision to use it for 21 days. Till the child is 8 years or 10 years, if you want to use doxycycline or tetracycline, you can use safely. It does not cause any tooth discoloration or pigmentation if used only for a period of 21 days. If it's a mixed infection, you can go for metronidazole. Aspirin is totally contraindicated in children till 16 years because it causes a fatal condition called Ray's syndrome. Present day practitioners, to make the child more comfortable or put the child to sleep, there's a tendency to add anxiolytics like diazepam, Valium. No. Till the child is 12 years, if you use Valium or diazepam, it's going to give an opposite effect. Instead of causing a sedation, it's going to cause an euphoria in kids. So till 12 years, avoid sedative drugs for children. Antifungals, topical is always preferred, fluconazole or topical nystatin. A lot of viral infection, topical acyclovir, you have 5% cream, which the patient dabs for about 3 to 4 times a day for about 7 to 10 days. Chlorhexidine gluconate is a good antimicrobial. We have started using topical corticosteroids in pediatric practice. Mostly it's the common triamcinolone, which is a 0.01% cream. How much do you apply? That's the question all of us have. You prescribe a Kenacort or a Turbocort or a test 3 times a day. How much the patient is going to use? How is the patient going to use? You don't have any measuring thing to use it. The unit what we use is 1 FU, which is 1 finger unit for an adult. For a child, it's half FU. From the tip of your fingers to the first line, that's 1 finger unit for an adult. Half is for a pediatric. So each time a child or a parent is going to take half of the finger level of the child, not of the parent, of the child, and then apply it over the lesion for about 15 to 20 minutes, 3 to 4 times a day, maximum for 7 days. After application, the instruction what you need to give is do not eat, drink anything for half an hour. Then the kid can rinse the mouth. So we have from a low potent steroid to a very, very high potent 0.05% of clobetasol propionate for very severe cases. The last part of pediatric oral medicine before we go into the case scenarios is informed consent. Mandatory in the present day where legal systems are waiting to